And that focus has taken us all over in terms of our policy agenda. We're really focused on the National Health Service Corps and have been since our inception, and has brought us to the world of BIPIC and national cooperative agreements. I'm sure you've heard of a lot of us. There's a national network of 20 of us that are all different national organizations focused on different elements of helping health centers get whatever they need to be successful. So ACU holds a national cooperative agreement focused on clinician recruitment and retention. So we call that project the STAR Center, and we are delighted to be able to talk about recruitment and retention all day, every day, and especially appreciate the time to chat with you all today.
Thank you, Allison. Thank you so much. And it's such a great honor for the National Center for Health and Public Housing and for me to share knowledge and content with Allison. She's been very supportive, and I appreciate that. Thank you, Allison. And we also have on the line the National Nurse-Led Care Consortium. I'm not sure who is on the line. Good afternoon.
Hi, Jose. It's Emily. How are you?
I'm good, Emily. How are you doing?
I'm well. And hi, Allison. Allison gave an awesome overview of what an NCA is, so I don't know if I'll need to do that, but I can talk a little bit about NCC if that's helpful.
That's great. And what you are doing to address the diabetes issue.
Yeah, absolutely. So like Allison's organization, the National Nurse-Led Care Consortium also holds a national cooperative agreement through BIPIC. And we, as an organization, we sort of advance nurse-led care through policies, programs, and research. But we also work with a variety of providers around just improving outcomes for vulnerable communities, especially residents of public housing, which is what our NCA is focused on. And so like North American Management and like Allison's organization, we are working on sort of helping providers address diabetes in their clinics by providing culturally competent and coordinated care for patients. So we're excited to join you all today in this discussion. So thanks, Jose.
Thank you, Emily. And thank you so much for being on the call. Do we have somebody else with you, Emily, today?
Our Director of Training and Technical Assistance, Christine, will be joining us, I think, but she's just hopping off a different call, but yeah.
All right.
Yep.
Hi, Jose.
Here she
is.
Sorry. Hey.
No worries.
Please introduce yourself.
Sure. So my name is Christine Ganella, and I am the Director of Training and Technical Assistance at the National Nurse-Led Care Consortium. And I think Emily did a nice summary of some of the work we do. More specifically, we've been really looking at care team formation and optimization as a way to sort of help move the needle on diabetes outcomes. We also are participating in some statewide efforts around the DPP, the Diabetes Prevention Programming through the CDC, and have done some sort of local programming with a nurse practitioner and public health nursing model to do some diabetes support groups within some of our health centers in Philadelphia. So that's just a kind of a broad brushstroke, but we're delighted to be on the call today, and thank you for the invitation.
All right, thank you so much. And I see Dr. Rita Glav on the line.
Yes, good morning, everyone, or almost good afternoon.
Good afternoon. And Dr. Glav, can you introduce yourself so the
Sure.
audience know who you are and where you are?
Absolutely. I'm the medical director at TCA. We were the first housing project in the city of Chicago. It was built for the Second World War veterans and has gone through a lot of changes and is actually going through a little bit of a renaissance. They're building new units, rehabbing new units. And we have like many of the health centers, probably about 48% of controlled diabetics, which I hate to say, but that's something that we all struggle with, and I look forward to participating in this quality group.
Thank you, Dr. Glav. Thank you so much for your support. Do we have anybody else on the line from the health centers?
Yes, hi, I'm Dr. Silky Irizarry. I'm calling from Med Centro in Ponce, Puerto Rico.
Thank you so much. And that she is with Med Centro, and we've been working with Med Centro in Puerto Rico for many, many, many years. So thank you so much for being on the line. I believe this is your first time participating on the call, right?
Yes.
Thank you so much. So is anybody else from the health centers? Well, all right. So we have Dr. Glav, and thank you so much for being part of the call. I received probably 6 or 7 confirmations, so hopefully they can join us as we can continue the conversation on diabetes team-based care. This is I'm not sure you are just on the phone or if you will have to join us using your computer, but I have some basic slides here to lead the conversation. And first of all, I need to share with Dr. Glav that yesterday we were part of the Diabetes Task Force webinar, and we shared some of the best practices and all the information that we have received from all the health centers participating on the call. So thank you so much. It was very useful. And we used all the previous content from the last 2 conference calls to create the content for the webinar. So thank you so much. And then in regards to the topic that we are going to discuss today, specifically, we are going to talk a little bit about the team care for people with diabetes. As we know, this is a complex disease and affects people from all age groups. It's very important to have all the staff that is needed to provide services like prevention and health promotion and primary care, vision care. We need to have non-clinical staff doing outreach, and sometimes we need the specialist team care and health IT support. And in addition to that, we need to report on the measures, and we also need quality improvement personnel. This slide basically showing in an ideal world that all the people that we should have as the healthcare team helping people with diabetes. Pharmacists, podiatrists, optometrists, dietitians, nurse practitioners, nurses, community healthcare workers, mental health professionals, and all the staff that should be involved in the care of people with diabetes. The idea basically is that if we have the right staff, then we can improve the patient experience of care. We can improve the health of the patient with diabetes, and very important, we can reduce the per capita cost of healthcare. So the goals for any team providing diabetes care is to control the A1C in diabetic patients and take care of all the other chronic conditions affecting people with diabetes, and provide meal plans and engaging people in physical activity, and recommending avoiding tobacco use and taking medicines as prescribed, and that's how these people can cope effectively with the demands of a complex chronic disease such as diabetes. So in addition to that, the personnel needs to be involved in all the key messages, and specifically emphasizing the importance of taking care of their disease and helping them with coping skills, recognizing so they can recognize the danger signs for food and dental problems and seek help from the other providers. So the idea that we have today is to ask you some questions about the in regards to the staff that you have, some of the needs, and what you have been able to achieve. I would like to turn it over a little to Allison, as she is the expert on staff recruitment and retention and everything regarding to staffing in public housing, specifically in health centers. So, Allison, take it away.
Thanks, Jose. I don't know that I call myself the expert. I'm always still learning, certainly. It's been a wild ride the last few years. I feel like as soon as we get things settled on recruitment and retention, something new comes up. Big change in the market, big change in focus on, which chronic diseases we want to focus on, and there's always still more to go. So I'm honored to be able to chat with you all today and pick your brains a little bit and hear about what you're going through and figure out what resources our groups can support you with and what resources maybe don't exist yet but that we should build as you're struggling or continuing to grow in your efforts to help your patients manage their diabetes better. So as I mentioned, the STAR Center is really focused on recruitment and retention. And so to that point, we've spent a lot of time thinking and talking with people about, okay, what people would you might need to recruit to a team to have a comprehensive care approach to helping your patients manage diabetes in ways that maybe previously have been more difficult. So maybe it's adding new team members. That's one big component. And then the other thing is retaining team members you have as you're sort of managing a lot of this. I hear from a lot of folks, and I'll be interested to hear from the folks on the line about kind of the pressure and the burnout a little bit that kind of managing some of these issues can really cause. Having 48% of your patients who could have controllable diabetes and feeling in some ways like the resources and the environment that you have is not conducive to getting those results can be really frustrating for folks. So in that sense, on recruitment retention, I think we're really interested to talk today about recruitment, what types of staff members and team members do you need to have to help you with this challenge, public health challenge, and then in terms of retention, what are some maybe ways that you can mitigate burnout, frustration, or kind of overall feelings of being overwhelmed for folks who have been in the good fight for a while. So I guess, does anyone have any immediate reactions or questions or feelings or thoughts on any of that? Hearing none, I'll assume your minds are working overtime. Well, then our time today is really then going to be focused on kind of some dialogue. So I'll be ready to call on you guys. So brace yourselves. But we'd love to talk through just some current questions we have about what you guys are already doing in an effort to address diabetes. So who wants to go first? We'd love to hear about the current composition of your care teams and how they are or are not structured to help folks managing their diabetes.
Well, I can start. I'm Dr. Silke Irizarry from Puerto Rico. I'm the quality director here. For diabetes, we have 3,000 diabetes patients here in the clinic from 40,000 patients total. It's a lot of people with diabetes in Puerto Rico. As you know, diabetes in Puerto Rico is epidemic. It's genetic disease here. It's very common. Not all of them are controlled. We developed a year ago a program, a collaborative of diabetes. Now all our diabetic patients are sent to the internal medicine department, and they're being attended there. There's a special day for them. Tuesdays or Thursdays, I don't remember which one, but there's a day for them. And there we have a team of nutritionists, health education, internists, a nurse, all of them dedicated to them. We also developed a wellness program for those patients. We have a spinning program for them. That's what we have been doing so to help them. The problem is since Maria hurricane, we're having trouble controlling our patient because the nutritional, we have a lot of problem there in the adherence to treatment and to the diet. We in Puerto Rico, I don't know if you know, net practitioners and physician assistants are not legal, so they cannot work here. Only the physician and the nurses, regular nurses, are the ones who are attending this patient here. Any questions?
No, thank you so much. I just have a very quick question. When you have either a new patient with uncontrolled diabetes, or when you have a patient, an existing patient who develops uncontrolled diabetes, what is the process that you have to try to bring the numbers of the A1C down? Who is the first person who sees the patient, and if there is any kind of referral to other specialized services?
We automatically refer to endocrinologists here in Ponce. There's one endocrinologist who receives them and treat them. She write down the treatment recommendation that she gives, and we follow it, and follow the patient with all the team that we have here to work with them. Also, those, all diabetic patients are seen by internists, a medical specialist in internists. No other physician see them.
And when you have to follow up with the patients, I am assuming that in Puerto Rico you also have the outreach workers and the nurse or the person who is responsible for following up with the patients. Who is basically doing that activity?
The health education personnel.
Okay. Is that a particular? I mean, is that a title in Puerto Rico? Like for instance, in the continental U.S., you have diabetes educators and they need to be certified. I'm not sure if that is the case in Puerto Rico.
They don't need to be certified, but our is certified.
Okay.
They don't need to be. They only have to have a bachelor's degree in health education.
Excellent, excellent. Thank you so much. Dr. Glav, what about
Yes.
everything in TCA? What personnel do you have? What staff? And what are your needs in regards to diabetes and the services that you provide?
Well, I think I need one of each of those that Dr. Puerto Rico has. But, I think when you work at different places, you work with what you have. We only, I think, I've worked at a few settings. So ideally, we can talk about ideally what would be great. I think certified diabetic educators are fantastic in the sense that they can not only educate your patients, they can also bring all of your staff up to date. I think they make regular docs like myself very comfortable changing insulin formulations, talking about carbohydrates. So if I could pick one person that I could afford to have, I'd like to have a diabetic educator, just because of the impact they have on the entire system, especially in clinics like ours, which currently our main site is in a housing project. Things that are very, and I'm speaking generally, sometimes housing projects are a bit of an island. So if you can have someone who can educate the people on the island of the housing project as well, it will also help for maintaining continuity through the providers, clinical staff, and patients. I think monitoring, whether it's in a registry or having a portal or utilizing your EMR to track your population of uncontrolled diabetics as well as diabetics, regular diabetics, I think is key. And then if you get the bells and whistles, having nutritional support, having access to exercise, having access to fresh fruits and vegetables, and having an in-house discount pharmacy. If I had my wish list, I could probably do all right with just that. Mm-hmm. I mean, that's just been my experience. I think you can teach, any provider teach a patient how to learn to inject. My experience is if providers are comfortable teaching their patients how to do insulin, they leave even the day you gave them, I want you to start on insulin talk, and show them how to do it. You probably have a 50% leg up on them actually incorporating insulin more quickly. So questions to me,
Sure.
I currently
I
have
have
no
a follow-up question for
Thank
you,
you.
Dr. Glass. Specifically, specifically when your patient needs a specialized care. You
Right.
know, do you have optometrists? Do you have foot care specialists? Do you have doctors who specialize in kidney diseases to provide those services? And if not, as part of the 19 program requirements, you have to have some agreements with hospitals and other clinics. So what do you have in regards, and what you don't have in regards to specialized care?
Okay. So we have an optometrist who comes once a month. We can refer to the Illinois Eye Institute, which we have an agreement with. But our problem has been high no-show rates for patients who even qualify to go, and they go, but they don't go. So they don't go to the visit. So having the optometrist here at least is good for screening for retinopathy. Now, nephrology and endocrinologists. Here in Chicago, it's very difficult to get a visit with an endocrinologist or a nephrologist. And that sounds paradoxical because I have 4 major teaching hospitals here. But they don't want to see patients unless they're on the brink of renal failure, I think. So unless my patient, yeah, that's my experience at the housing project. So what we do with patients is we do the screening for the microalbumin. We trained everybody to do that and at least pick out your patients who have accelerated increases in creatinine and are needing more immediate care. So yes, it's a struggle because a lot of patients have gotten insurances that are very poor. And so that's the struggle is they don't see them until they're right in renal failure. And we're talking chronic renal failure at that point. It's not even acute.
Mm-hmm. Mm-hmm. Now, in regards to food care, which is another important part of the examination of patients with diabetes, do you have a podiatrist? I'm sorry.
We do not have the podiatrist here. We do the monofilament exam for patients.
Mm-hmm. Okay, and if there is any need, like for instance, if a patient develops an ulcer or a complication, like a microvascular complication, do you refer the patients for additional specialized care?
Yes, we refer out.
Okay, excellent. Allison, any other questions that you would like to ask?
Well, I'd love to hear more. You know, I heard the wish list, which I loved and totally support. I would love to hear a little bit about some challenges you're having kind of making that wish list happen. So, you know, specifically maybe starting with that diabetic health educator, you know, what is your experience about why it's hard to bring that team member on?
Well, the diabetic educator, I think is a good investment, but the average for diabetic educators now here in Chicago about $75,000 a year.
Mm.
So, yeah. And again, recruitment of staff in general is difficult for us, but specifically for that diabetic educator, I have put out looking for one, but I haven't been able to find one, nor a nutritionist. So, I mean, I think what happens is all the uncontrolled ones get put in with Dr. Glab, and then the other ones float around till Dr. Glab goes, "Oh my God, didn't anybody really want to put you on insulin? Oh, they didn't know how. Okay." So, you know, it's I think the wish list is fantastic, but I think there's a lot you can do yourself. I don't, you know, it's a question of training and comfort. but I hate seeing, I referred them to the endocrinologist, and I'm just thinking to myself, so when do you think they're going to get put on an insulin? 7 months from now?
Yeah, that is true. Now, this question is for both Dr. Irizarry and Dr. Glab. I'm quite sure that you are aware of the rule banning smoking in public housing.
Yes.
And that one of the main topics, I believe, for education, specifically for diabetic patient, is to educate them, specifically they are smokers. Is there any activity that you are doing with the diabetic population in regards to smoking cessation? Do you have like some kind of peer specialist? You know, we've been in contact with HUD, CDC, and other agencies, and one of the questions that they have is whether health centers have peer specialists, and they define peer specialist as someone who has walked in the patient's shoes, basically. I mean, they are referring a current, or I'm sorry, someone who smokes and is not a smoker anymore, or a person who is a public housing resident and has a connection with the health center to provide some kind of smoking cessation education to patients. Is that something that are you doing either through a peer specialist or an outreach person?
I don't have that.
You don't? Okay. What about you, Dr. Irizarry?
Well, in Puerto Rico, we have a cessation tobacco use program here. The Health Department of Puerto Rico have a program. We refer the patient to the program, but the health personnel here, the health educator, she also works with the patient by face-to-face encounter. We help them. We don't have medication for quick smoking. It's here because it's too expensive. Patients don't pay it. That's the only thing we do. We all, in all the encounter with the physician, we ask them if you're smoked, not. If they are a smoker, they're referred to the health educator, and she's the one who refers them to the health department.
Okay. Now, does the health department provide a smoking cessation treatment? I'm not sure if in Puerto Rico is covered by Medicaid.
No, it's not covered.
Okay.
They offer the program to the patient. The problem is when they ask the patient to pay for it, so they decline.
Okay. Thank you.
Some of our providers, we have behavioral health. Some of our providers do refer to behavioral health. We do offer tobacco replacement like nicotine patch. We also have Chantix and Wellbutrin. We screen every patient 12 and older, and we look to see that they've been referred for some kind of smoking cessation treatment. I do it with my patients. I put them on Wellbutrin. We agree to a decline in the number of cigarettes they're actually smoking. You can have them come back in 4 weeks and see how they're doing. And I would say conservatively, about 25% of patients, when they're ready, if you do Wellbutrin plus keep an eye on them or offer them quitline if they don't want to come in and check in with you, are able to at least get down to 1 or 2 cigarettes or completely quit. So I think just having that recurrent conversation with them, and then I talk about flu shot, and I'm just very frank with them. You know, you have to be ready. You can wean yourself off. We can give you support if you need support with medication. It's not addictive. I go through, you know, it might give you some vivid dreams. Specifically, Chantix does that. You don't have seizure. It's probably going to work fine for you. Remove the other co-smokers in your home, or at least get together and decide to quit together. I think, you know, it's just reintroducing the conversation. I think having the housing authority make that a requirement, I think is a great thing. I think that's very important to people. I'm going to lose my house because I'm still smoking. See about this. This a little bit more. So I think, all those things help. Education, having some kind of real incentive like that, I think is important. But again, I think it's, as many people are comfortable with. I'm an old lady. I've really gotten away from referring out. I think I'm not being verbose, but I think my opinion is spending time with the patient is important to them. And when I say, we can do this, you just need to be ready. I give you the tools. I'm your coach. Come and see me. If you fail, it's okay. The average person fails 5 or 6 times to give up smoking, but then they're successful. I think the message of the physician is fantastic. If you have the team, great. If you don't, lead the team.
That's right. Dr. Glaff, if I'm not mistaken, correct me if I'm wrong, TCA has 2 clinical sites.
We have 4.
4. Okay, sorry.
We have a mobile van, we have a school-based clinic, we have a new site, and then we have our main site within the housing project.
All right. Because I am familiar with the main site, and you have the public housing site, if I'm not mistaken, right?
Yes.
Okay. The question is, how many physicians do you have for the 4 clinical sites?
We have 1 full-time. We have another family doc, 2 part-time family docs, and 4 mid-levels.
And when a patient, either a diabetic patient or someone who smokes, need, for instance, if you are a smoker, you need some kind of behavioral health intervention.
Yes.
And I had the opportunity to meet Antonio, and he is a great person. Is he the person who is doing all the behavioral health interventions?
We have also a social worker.
Okay.
I think even though we're in the same building, we've really had a problem with patients no showing. So when he's not with a patient, or he can come over and the patient's willing to talk about, that additional visit, then that's great. I've tried to get him in to do just the PHQ-9 with my diabetics and then talk about any additional issues. But I don't, I feel like it's a wasted resource sometimes. And his appointments in general have been 30 minutes to an hour.
Okay.
And so, I think that that's just a big investment sometimes for patients, and they're not willing to do that.
Okay, and Dr. Irizarry, is it the same in Puerto Rico, specifically at Med Centro? Even if you don't offer the pharmacological treatment, do you have behavioral health people for diabetic patients? Yesterday, when we had this webinar, we had the participation of the American Diabetes Association, and they mentioned some statistics about the need of psychological intervention for diabetic patients, and it seems that they are twice as likely to have depression and other mental health conditions. Do you offer that service?
Yes, we have a mental health clinic here. We have 5 psychologists. One of them is specialized in substance abuse. All the patients, the diabetic patients, once a year are referred to mental health. We have the PHQ-9. We do that every year to every patient here, and everyone who is positive is referred immediately to the mental health clinic. We have 5 sites, 4 mobile units. We go to 5 different public health centers, buildings, and we have 56 physicians here in total.
Okay. Now, this brings me to the next question. All health centers have limited resources, specifically when it comes to staffing needs. And one of the biggest issues is burnout. How do you cope with burnout, and what strategies or what do you do for when since you have basically, in your case, Dr. Glab, you are the CMO, you have all your clinics and you do all this stuff. So how do you cope with that?
I don't know. I've been called crazy before, but I think for the providers, it's good to do during provider meetings, just, discussion about burnout, because everybody goes, oh yeah, that's right. To also, we have an academy here that someone that we have in admin, who's our development person, she organizes different speakers to talk about not only the providers, but all staff who serve, a high risk, high trauma population, how they can get through their day and, recognize when one is burning out or getting crispy, as I like to say. I have a crispy day. It's crispy on the edges. I think that sense of humor is important, but not everyone, not everyone feels it that way. I think our providers have time away from the clinic, their admin time. They're not required to be on site. Mm-hmm. I would like to go with them, but no. We have teaching like ECHO, which is the extension education program for the University of Chicago that they can participate in, which gives them CME. We give them protected time to do that. I think that is something that's becoming very important, burnout, and having common teams. But I think we're still in the infancy periods about, with providers like myself, where we were just kind of trained to suck it up, okay, and get through the shift. Right. That's how we were. Just like, okay, suck it up. There was no limits on the time you could be on call. And definitely for a lot of providers who are, at least in private practice, not in our practices, still live those lives. But I do think it's going to become more important, because if the provider is stressed, for sure, they cannot be a good champion for their patients. If the provider is like, it doesn't matter what I do, there's still going to be a hemoglobin A1C 10, and they're not going to take their insulin because they don't because I do hear that. I think sometimes it would be nice to play that back to the provider, because I feel like saying, well, maybe it's just the way you're feeling about it and you need a break and you need to go see, I don't know, do peds for a while if you're a family doc. Or I think that this requires a lot of self-reflection too about, so how do you feel? Well, why are you here today? So my CEO is very good about, think about your mission when you come today. Think about when you leave. What did you do today? What are you proud of? I think those are things sometimes are intangibles. And when we talk about recruitment, we cannot compete with the hospitals for salaries here in Chicago. As I think one of the speakers at the beginning said, there was a huge paradigm shift in salaries and what the hospitals are doing to align and take advantage of the changes in insurances. I think, our old adage of, they're here, they're committed to the community. I think that needs to be rebeefed and relooked at. It's not like everybody's a nun and a missionary. Some days it's like, man, I should have married that dentist, like my dad said. Out shopping at this stage in life. I'm still thinking. But anyways, obviously we do what we do because we want to do it. But I think there's really going to have to be, maybe there is in residency now, how to protect yourself from your own weaknesses.
Yeah.
I don't know how to answer that. I think it's something that needs attention for sure.
Great. Thank you so much.
The poor doctor in Puerto Rico's there, like, you should come over here and see what we're doing. Give us some real problems. Okay.
Dr. Irizarry, same question for you.
Well,
How do you, I mean, I'm not sure if burnout is an issue at Med Central. The question is, how do you cope with that? And this, the other question that I believe it has nothing to do with burnout, but I am interested in knowing is whether, do you have a residence program at Med Central?
no, we don't have a resident program, but we receive students from the medical school here in Ponce, and we receive OBG residences from different hospitals in Ponce, because we have 3 school hospitals here, and all of them come here to study, to practice.
Okay. Okay, but are
And
these,
yes, we have
are
burned
these,
out here in Puerto Rico.
sorry?
We have burned out here in Puerto Rico, but it's easy because we only work from Monday to Friday, and we can go to the beach in the weekend. So,
Well, that's right. You have
and
you have
because
that
you know
great
Puerto Ricans,
advantage.
we use humor for everything, so it's easier here. I think it's easier.
Alison, do you have any follow-up question?
Well, is there somebody else who was typing up there?
Yeah, this is Joy Mockbee. I was
Oh,
just going
Dr.
to comment
Mockbee,
on
good afternoon.
Good afternoon. I was just going to comment on the physician burnout because we've done a lot of work around that. And one thing is just getting our physicians involved in our quality improvement and patient satisfaction projects. We have a lot of different projects going on, and just giving them that voice to be able to make decisions around what's causing the area, what really impacts their day-to-day work in the clinic. I think that helps a lot. And then we formed a clinical innovations committee, which is driven by clinicians around basically whatever topic they wanted to take on. And the main topic they spent the first couple of years really looking at was how do we decrease the EMR burden, and looked at a lot of different options, and ultimately ended up going with scribes. And so since we've implemented that about 2 years ago now, that has really helped a lot with provider burnout. It has been pretty dramatic as far as decreasing the huge workload at the end of the day. So it hasn't solved all the problems by any means. There's still a lot of work to be done, but I think that's really been very helpful. And then we've had some workshops on mindfulness and meditation and how to incorporate those throughout the day, and allowing more, and also some optional workshops that providers could go to on those topics.
Thank you so much. And I just want to let everybody know that Dr. Mockbee took some time out of her off day to be with us. So thank you so much. You know, I am somehow contributing to her burnout. So I'm very sorry.
I like the Clinicians Innovation Group. I'm going to steal that. Is that okay?
Of course.
Absolutely.
I like that title.
Happening.
So, Alison, do you have any follow-up questions?
Yeah. I mean, thanks so much for sharing it. It sounds exciting. I'm as excited by the Clinical Innovations Committee as others on the line. I'd love to hear from you, Dr. Mockbee, and others about other kind of workflow and process pieces that you may have changed or implemented to address either the burnout issue or, again, back to the diabetes question of the day.
Yeah, I'm Dr. Glab. We just thought about that, and I think it's I just needed a name for it. The Clinicians Innovation Group. We have clinicians serve on the monthly quality improvement team, but we came to the conclusion that I may think it's a fabulous idea, but if it doesn't come from the clinicians who are complaining the loudest, that they be involved in changing things, that you don't get, like you said, the satisfaction that you've had an impact to at least mitigate some of your frustrations. I think that's a good idea, to get people involved, not just to critique, but to come up with some constructive ways. Okay, so if this is really irritating to you, how can we put it into the workflow? I think that's important. So I like that. Clinicians Innovation. That's what we're going to call it now. I like it.
That's great. That's great.
Absolutely.
Now, Christine, do you have any questions? Or Emily?
Thanks, Jose.
Oh, go
Yeah,
ahead, Christine.
so I wanted to Puerto Rico and yours. I know you sort of briefly mentioned it with Maria, but how you sort of balance this situation that you're facing, this this emergency, this crisis that you face, and also sort of keeping your day-to-day operations and priorities in check. I was wondering if you could just speak to that a little bit more, because the sense that I get is that that still very much is present in how you are prioritizing your roles and responsibilities. And we're talking a lot about diabetes and and that's definitely something that's really important. But I'm just curious from your perspective how you're balancing those different priorities and then this crisis that you've just experienced, and kind of keeping everybody moving forward and on track with caring for your patients and keeping the health center up and running.
Well, we were really prepared for this. In MedCentro, we never stopped giving services during or after the hurricane. We have energy, we have water, because we have electric plants and everything. We even give support to the hospital in the area, because they didn't have energy, and they come here with their passion, and we give service to them. We offer our refrigerators to the patients. We give them the insulin. We keep it here. Everybody who have problem with asthma, they receive their therapy here, all free of cost. We still having trouble with the aftermath of the hurricane, because in Puerto Rico it was like 30 years that this didn't happen. Is for our generation, it's the first time we have to confront this, and it's been hard. Now 80% of the island already have energy, but we're still having trouble with the services. There's a lot of physicians that left the island, and everybody lost physicians, nurses, everybody, the staff. Everybody here who have clinics lost staff there. A lot of people left, and educated people is the one who's left. So we're still working on it, but in MedCentro, we didn't suffer as much as others, because we really were prepared for that. Any question that you want to know? How we've been working. Our diabetic patients, we even visited them in the houses with the outreachers. So we check it out them, is the insulin were okay or not. We have all the medication for them also here.
Oh, that's interesting. Thank you. I really appreciate that feedback. That's really interesting. And I think in particular, how you just continue even in most adverse situations, just staying mission critical to what needs to happen, and how, oftentimes when you're sort of stripped down to the bare bones of what you have to deliver on, you stay hyper focused to that and make it happen. I think that's I think I really appreciate just sort of hearing how you are just continuing to move your mission forward under those circumstances.
Thank you.
Thank you, Christine. And I have a follow-up questions on Christine's question. I am probably speaking without knowing all the facts, but how did you prepare for the emergency, specifically for your diabetic patients? You know that they were going to need insulin. Probably some of them may have problems with their prescriptions, specifically if they need to fill new prescriptions. How do you prepare for that event, and how long in advance?
Well, in Puerto Rico, we were in the watch for an earthquake. We already been 100 years without one. And 2 years ago, our executive director prepared the institution by physically preparing it for providing water and energy for the center for 72 days without needing to be connected to the mainland. So that's how we were prepared. We have identified all our diabetic patients. There was a word before the hurricane because it already was announced. So we know what was coming a week before. We didn't know how hard it was, but we know it was a hurricane coming here. So we called the patient. We overstocked our insulin and medication. We asked all the patients to come and receive 1 month of medication free of cost, and they came, and they take their medication. People who doesn't have energy, they can leave here and come every day to have their medication, their doses done by our physicians and nurses. There was no category. Everybody do everything here. No matter if you're a physician, you do every job that you have to do. It was good because we go back to be working for help for patients by the heart. It was good for us too. It was a bad, it was a lesson, but we go back to be people, as we say here in Puerto Rico.
Thank you so much. Thank you so much. Now,
and it just makes you. Oh, I'm sorry, Jose. I was just going to say just a comment. It just makes you sort of think. When we talk about sort of care team formations and optimization, that you can have sort of that your care team feels equipped to be able to respond in the event of something like that is pretty powerful. And I think that's sort of, that's the optimal goal, right? That you can have a care team that can bend and flex to what the needs are of your patients and sort of the circumstances that they're facing.
Mm-hmm.
Yeah, I agree, Christine. I totally agree. And then I am assuming that you had to work extra business hours and then night shifts and all that stuff.
We spent a month here working every day, even Saturdays and Sundays, and everybody did it because we were needed. In Puerto Rico, I don't know if you know, the primary care 330 centers are the only one who respond for the emergency. So we work a lot.
Yeah, I imagine. And we go back to the burnout issue.
Yeah, it's the first time in a long time I've been listening to burnout. We don't even talk about it here. We don't want.
Well, but unfortunately, the hurricane season is around the corner one more time.
I know.
I hope, but I really hope that we don't have like a violent hurricane season. But are you taking all the measures and everything that you need to get prepared again?
Yeah, we're doing it again. And again and again. It's part of being living in the paradise.
That's true. I would like to ask now Dr. Mogby. This is about outreach, specifically for diabetic patients. We know that health literacy is a big issue for some patients, for some of your patients, specifically when you have populations that are not native speakers, and when you have a population over 65 who probably do not understand the prescriptions and the labels and all the information. And sometimes you need to dedicate extra time to these populations. So who is addressed, how do you take care of those who are identified as having health literacy issues? For instance, the pharmacist in some of the health centers is the person responsible for explaining and giving instructions to patients, but who else is doing all that, doing those activities?
So we're fortunate to have a robust team, and it really is the responsibility of everybody on the team to be aware and to constantly work on communication with patients. around health literacy. We do have somebody who is sort of a health literacy specialist who reviews much of the material we use, although unfortunately the EMR has set us back in that regard because some of the things that we can't control as far as information that's given to patients through the EMR has, suboptimal as far as literacy goes. But all of our other materials and things we vet. And then we do have, the pharmacy team, the behavioral health consultants also really, through their motivational interviewing approach and just really focusing on what the patients are understanding and what they're, where they are in the stage of change and what they want to focus on, that can really bring to light where they are with their health literacy, and then using those techniques to help convey information to them. And then, of course, the MAs, they routinely ask, I think it's definitely at the first visit, and then I think it's maybe once a year, they ask patients about their preferred methods of learning and communication. And so and that's documented in the EMR where we can refer back to that, whoever the team member is. And then for our more high-risk patients, we have RN care coordinators who check in with them either by phone or when they're in the clinic. And so they look back at that information the MA has gathered and use that.
All right, thank you. Thank you so much. What about your patients at TCA, Dr. Glav? With, again, health literacy is a big issue, and specifically when you have a diabetic patient who is on multiple medications, sometimes they need insulin and non-insulin medication. Who is the person responsible for making sure that the patient follows all the recommendations and the patient doesn't have a complication for like a hypoglycemia or anything else?
Right. So we do have an in-house pharmacy, and they do explain, especially to patients who have new medications, but primarily it is the provider who does that. As I said, I keep harping on this, I didn't have a nurse for 9 months. Basically, it's the providers and our pharmacy. Again, I think I'm a big advocate of having the provider explain the importance of it and having them follow up. I do a close follow-up about a week after I start a patient on insulin. I just want to make sure that connection is still there and that they're comfortable using the meds and that they've gotten the meds. But having the pharmacy, they're very comfortable giving that kind of information.
I'm sorry, follow-up question. Who provides the initial education, like the use of the insulin, how the patient can inject the insulin and follow up on whether the patient has learned what they need to learn?
The provider.
The providers. So it's not the pharmacist, but the providers.
The providers, yeah.
Okay. All right. Dr. Irizarry, in Puerto Rico, you don't have a language barrier, I guess, but
no.
you have people that, due to low literacy, probably do not understand the instructions. So, who is responsible for making sure that the patient is following the recommendations and the prescriptions as how the provider prescribed all these medications?
We have 3 people who are responsible for this. Is the provider is the first one. He's the first one who have to teach his patient. Explain the medication, how to use it, how to apply the insulin. Then he refer this patient to the health educator, and we also have in-house pharmacy. And our pharmacy, the 3 of them, they're doctor in pharmacy, and they also have an area where they sit with the patient and teach them again how to use the medications. That's how we do it here. We don't have a barrier in language because we have 90% of the people here speak Spanish, and those who speak English or other language, even sign language, we have two of our staff that speak with sign language. So
Mm.
that's not a problem. But we have illiterate people.
Yep.
So we coordinated by color the medication, and we give it the box with color and explaining how to use it.
Okay, okay, that's I believe that's very useful, specifically for those having AM and PM medications, or they have to inject insulin more than once a day. That I believe that's a great idea. Allison, any other questions?
No, I see we're at time, so I just want to thank everybody for sharing. I've learned so much this hour.
Thank you, and I don't have additional questions, so I would like to thank again Dr. Irizarry, Dr. Joy Mogby, and Dr. Rita Gla for being with us and sharing the information and sharing best practices with us. Thank you so much for all your help and support.
Thank you.
Okay, take care.
Thank you, and have a great afternoon.
You too. Bye-bye.
Good afternoon.
Bye.
Bye. Thanks, Jose. Bye.
Thank you. Bye.